Hi everybody. South African accents are appalling, and I've got wonderful old friends in this room, so forgive the personal waves. When we talk about superbugs, for a start, the term is a press construct. And I think in the ICU setting, you tend to think of them as organisms that are difficult to treat, largely because they've become multiply drug resistant, or organisms that have changed virulence characteristics over time through fairly sloppy mutations like C. difficile that becomes hypervirulent. But very few of us realize that a lot of the superbugs that we're talking about are organisms, especially the ones that you encounter in hospital wards, of relatively low virulence. The true superbugs that we consider in the world of microbiology infectious diseases are viruses like Ebola, organisms that are not targeted for man as an endpoint of infection. Man is a disastrous event for an Ebola virus because it kills its host very frequently, and with killing its host, it burns out its life cycle. But it's an organism that can cause the most profound sequence of pathology in human beings, and it's probably one of the most devastating agents that you can see causing infection in human beings. So I'm going to move away from the traditional paradigm of the bacterial superbugs that you hear about and really refer to probably the biggest superbug of them all, which are the filovirus family agents, Marburg and Ebola virus. So my tirade about superbugs is what it is, and I want to maybe start the argument of this lecture by saying to you that we always seem to think of infectious diseases as being caused by the infectious agent. So the superbug is the virus, is the germ. And I hope that you'll understand, specifically when we deal with organisms all the time like these in the field, that perhaps we need to redefine superbugs towards the end of the talk, because the agent is but one factor in the causation of infectious diseases. The rest is orchestrated by everything that is completely non-microbial, and that's a very important point. The movie Outbreak really didn't do the world much favors. It was a wonderful, riveting watch, I think, for all of those of you that went to see it. But Outbreak and Contagion really dramatized and fictionalized real viruses to some degree, creating hybrid concepts where these viruses, instead of being transmitted by the contact route, which is what the viruses that we deal with in the field are, become airborne and immediately sweep through populations and kill people at the rate of knots. And in these kind of movies, there's always an element, which you will see as my talk evolves, also comes through in the social media, there's always an element of an undercurrent of conspiracy, that these are created agents, that they're to damage mankind, that there are vested interest groups that are putting them out so that there can be gain. And hopefully you'll be persuaded that this is far from the truth. But please remember that all of these messages, and especially in fact reinforcement of incorrect information through social media, can really do tremendous amounts of damage to an outbreak response team and in fact impact on the epidemic curve in a big way, and you'll see how that works. So the filoviruses effectively are a genus of viruses, or a family of viruses that are strand-like viruses. Phylum in Latin is a thread, and they're so called because they're thread-like when they're viewed under electron microscope. And they're all very simple RNA viruses that are exceptionally easy to kill and inactivate. On their own, they can do very little. They require hosts in order to multiply and make more copies of themselves. They're not encapsulated, and you can destroy them even using ordinary detergent activity of soap and water. So you don't even need the bleach that we use in the field in order to get rid of these. So exceptionally delicate, but very virulent when they enter hosts and cause disease. The filovirus family is divided into two genera, genus Ebola virus and genus Marburg virus. And 4 of the 5 Ebola virus genus agents are on the African continent. So the true out of Africa agents. There's Budimbug Ebola virus, which is in fact from Uganda, Sudan Ebola virus, obviously from Sudan, Thai forest from the Ivory Coast, and Zaire Ebola virus, which is probably the most virulent of the whole lot. Now, previously, as you'll see, as we go further into the talk, the only agent that was filoviral in nature found in West Africa was a single case of Thai forest Ebola virus disease, which occurred in a person who was an animal behaviorist. She came across a primate that was not well, engaged with this animal, and came down with a disease that seemed to be a lot less virulent than all of the other strains. Zaire Ebola virus is, or at least a variant thereof, called the Makona strain, is in fact the strain that is the prevalent strain in the West African epidemic that started late in 2013, made a big splash as having started in 2014, and really raged on until this year. So Zaire Ebola virus is a dreadful agent. It's probably one of the most dangerous agents known to man, with a mortality that we thought in the early stages of certainly the West African outbreak would be in the region of 90%. I want to make a couple of important points. I'm talking to critical care physicians, which I'm not. We work in the field. We work with simple drips. We don't have electricity sometimes. We don't have water it's tanked in. And with simple supportive therapy, keeping the organs perfused, rehydrating patients, quite simply, we're able to reduce the mortality by catching people early and treating them early from a 90% mortality to a 37 to 40% mortality. And this is in the absence of ventilation, which is not frequently required, by the way, in these patients, until end-stage disease, in the absence of dialysis, in the absence of all the facilities that we have in first world countries. And this is an important message, because the first tendency is, let's keep away, we can do nothing for these people anyway, and they couldn't be further from the truth. And this became very clear as we became more aggressive with our early treatments of these patients in the field. My association, by the way, with hemorrhagic fever viruses go back to the mid-90s, where I started dealing with Congo-Crimean hemorrhagic fever viruses, already endemic in my own country, South Africa. And then in 1996, I had my first face-to-face encounter with an imported case of Ebola virus. And subsequently, I have been to every Ebola virus outbreak described on the African continent, Marburg virus, Rubella fever, you name it. That's become my infection control and my clinical management passion for reasons that I don't fully understand. It is almost a death wish, I suppose, but always come away alive and well, which is a second important message I want to make very clear to you. If you do things simply and properly and stick to infection control, it is very difficult for you to get the infection. So with common sense, with calm, and with good infection control, you will actually, and in a controlled environment that you have and we don't, these diseases are very manageable and not as awesome as they may seem to you. Now, what has been very interesting, if you look at the history of these viruses, that, by the way, probably have raged on for thousands, if not millions of years, in these confined ecosystems of tropical rainforests, is that although the virus was discovered in 1976 in a village called Yambuku in the DRC, and named after a river running through that village, the Ebola River, and almost contemporaneous at the same time, a completely different strain of Ebola virus called the Sudan Ebola virus was discovered in Sudan. What seemed to happen was that these virus outbreaks, although initially quite intense, kind of died down, and except for a laboratory outbreak in 1988, there was almost a 15-year period of silence where there was no obvious filoviral activity. And then from 1994 onwards, almost with a regularity of 1 to 2 years, right up to 2014, 15, 16, these outbreaks have been occurring on a regular basis. And particularly in Uganda, which was a very busy year for us, there was one event where we had, in fact, 2 outbreaks of Marburg virus and one of Ebola in the same year. So filoviral activity is increasing. And we don't really know why that is the case. You know, this is almost like an MCQ question when you say which of the following is correct, and statement E is all of the above. We don't know which of these plays the most important role, and probably there are many more reasons. But we know that in certain parts of Africa, certainly in Uganda, there's the Uganda Viral Research Laboratory, the UVRLI, in Entebbe, And in other parts of Africa, there are very well-equipped laboratories that can identify these cases quickly, characterize them molecularly, and bring out results pretty fast, enabling these countries to start launching responses early. The minute you've encountered the disease and people are sensitized towards it, of course, the pickup rate is also a lot more rapid. So Uganda is very well oiled in dealing with viral outbreaks, and so is DRC, to be honest. Other possible reasons are that we don't fully understand the ecology, the animal reservoirs of these viruses. Normally, there are no funds left, so by the time that these outbreaks roll out, you're so focused on the human response, on the public health response, that there's very little money left for people to do proper studies, getting veterinarians going in, capturing bats and other animals to find out what happens. So when the virus goes away and goes back into hiding, the trail of really, the hot trail, if you like, is lost. There's also really a very complex notion where people have done mapping, and I'm not saying that there's anything to it, but I'm just warning you, because one day it might be a surprise, juxtaposing Ebola virus outbreaks over areas where there's intense pig farming. And there seems to be a correlation between intense pig farming and, in fact, a concentration of the fruit bats that are particularly important as putative reservoirs of Ebola virus. So it could be possible, seeing pigs are very susceptible to the disease, and in fact are used experimentally to induce it, that some of the outbreaks going forward might be linked exactly to these concentrations of pig farming areas, and that might be something that we have to look at in the future. There's clearly, due with slash and burn type of vegetations and agriculture, the slashing down of wood forests, getting bush game, which is an important form of protein, and human encroachment on natural ecosystems. So these are infections that are accidental infections of man when they enter an ecosystem that is not their own. And so there's no cross-species efficacy here. If it enters man, usually for an Ebola or a Marburg virus, it's a dead-end entry. Increased human exposure due to people actually entering caves infested with bats, either because they're doing so recreationally or going into unused mines, is also important. And the notion that these viruses are occurring not just in remote villages, but in fairly large cities, including capital cities, which was the characteristic of the West African outbreak, is not surprising, seeing we're actually getting this complete expansion of capital cities, and there's no longer a clear divide between urban and rural. There's almost a grey area between those two, with movement and transport and infrastructure allowing people to be exceptionally mobile, so people that get sick in a rural area that is quite remote can freely find their way into capital areas as well. Transmission of these agents is important. It's important that you understand it because a lot of people are very panic-struck about what comes out with transmission. So in the first instance, and certainly what seems to be the case of the Ebola virus outbreak in West Africa, is that the first case probably involves some degree of contact with an animal in the bush. How it occurred, I don't know, and whether I believe the story is a different issue. I will not pass comment in a public forum, because a 2-year-old person who is deemed to have been the first victim is hardly going to be crawling around in African rainforests. But that's besides the point. That's the official version. But we think that initial cases occur from contacts with animals that are viremic. Bats are perfect reservoirs, particularly certain types of bats, like Egyptian fruit bats and others, simply because they will keep the virus alive but not get affected or killed by it. Viremic bats can excrete and also eat certain fruits and contaminate a wide variety of other animals, like primates, various types of other animals that constitute the so-called bush game. And when humans start hunting for these as sources of protein, effectively human infections occur. And from then onwards, the whole cycle is an escalation of human-to-human contact of infection, which is quite dramatic. So these bats are really quite interesting and dramatic in nature. They are large wingspan bats. Somehow, whenever you go in an outbreak area, they're always hovering over your head. Nothing ever happens to one, but it's not really nice to know that you've got these things, for example, in a hut where you're having a meeting, because you don't quite know what's going to happen at any point in time. They're certainly not vampire bats, so they're not there to eat you up in any way. But they are a delicacy. So bat soup and so-called barbecues of bush game can be found at any points on the street side that people have. The clinical features of this disease can be grouped in many ways, but the bottom line is there are no specific symptoms and signs. So people often ask us, what does a Ebola victim look like? Well, the Ebola victim looks like a person who has got septicemia or sepsis from any other agent. That could look like a malarial patient, a typhoid patient. All the diseases are endemic in the area present in exactly the same way. But I suppose one of the best characterizations, and it's important, is that the West African outbreak was largely marked by gastrointestinal manifestations, which has not been always a characteristic feature of these outbreaks. These slides you can have, so I'm not going to read word for word every slide because it's really quite futile, but the bottom line is that within a period of about 7 to 14 days, people become exceptionally ill. Hemorrhages start at around about day 10 to 14, and subsequently the death is due to obviously volume loss. Patients go into multi-organ failure. There is marginal bleeding that is visible. We always seem to think they bleed like fountains. They don't. Sometimes the bleeding is very discreet. Sometimes it's very obvious. When it's discreet, you will always find hematological abnormalities if you send stuff like D-dimers and other tests to the lab. But frequently these hemorrhages are not as manifest as they seem. So this is why we don't call it Ebola hemorrhagic disease, because sometimes you don't even see the bleeding. And we don't tend to call it fever, because sometimes these patients are apyrexial, just adding to the complexity of a really broad differential diagnosis. So for you to get the disease, you need to have direct contact with somebody who is excreting or secreting and is symptomatic and ill. If you're incubating Ebola right now and I shake your hand, and in your early stages of infection, I cannot get Ebola virus infection. It requires significant contact with blood and bodily fluids of a person, or people that are in convalescence who have got, in fact, infected fluids during that period and have had this disease. There is no evidence of risk from casual contact. So the first message the CDC and WHO puts out is that we go into the field, we have got the Ebola handshake, which is very butch. We kind of knock our elbows one against the other to prove to the world that we're not touching anybody's hands. But it's stupid because there's no science behind it. And when a population is under stress, to tell them not to hug somebody that is looking well and is a family member, to tell them not to go to market where the livelihood occurs, is actually exactly what you require to inflame the population. And then, of course, people get angry and people start resisting public health responses. So there are things that we need to remember. So obviously, people at risk of disease are those that kill animals during hunting, slaughtering, butchering, and food preparation processes. Cooked food does not transmit. People caring for Ebola victims, and of course, people that prepare bodies. Probably the body at the time of death for somebody who dies is at the highest viremia and is in every single organ. And you all know that when patients die, the sphincter loss, so urine comes out, feces comes out, and trying to perform terminal rituals of handling that body, which is customarily very important in African cultures, is in fact a death sentence, because that's exactly when you come into contact with those fluids that cause infection. Now, one way to see how a virus behaves in terms of its transmission is to look at a factor called Rho, that is a reproductive rate, or reproductive ratio, if you like. And it's not RO, which is what we say is R0, but that's besides the point. Rho is just easier to roll out the tongue because R0 is awkward. But effectively, this reproductive number gives you more or less an indication of what happens on average if one person with Ebola virus disease, in the absence of an intervention, in other words, there's no infection control, there's a direct exposure, what one person would actually potentially infect. And the ratio is 1 to 2, in the absence of an appropriate intervention. Now, that is important. Studies came out during this outbreak. In fact, they didn't come out, they were already published in 2011, where one unfortunate thing was quoted ad nauseum on Facebook and the social media. And this was a very flawed study where people put pigs in an animal facility artificially infecting with Ebola, created a certain meterage distance gap between a cage housing the pigs, and put monkeys or primates that are very susceptible to disease in a separate cage. And lo and behold, they found that the monkeys came down with infection. And the article concluded that the airborne route of spread of infection was in fact a likely way in which the animals got infected, which didn't make epidemiological sense, because you can imagine if something spread like, for example, TB or measles or chickenpox by the airborne route, you would have hundreds of thousands of cases, and pandemics would actually flourish very effectively, especially with travel. So it didn't make any sense. So when the study was really carefully scrutinized, they went and realized that people were taking high jet hoses and mechanically aerosolizing the bloody areas from where they were removing the dead pigs that were artificially infected and creating mechanical aerosols that sent spatters of blood as far away as those 5 meters into the cage of the monkeys. And the monkeys became infected by coming into contact with the material. So it's not airborne in the sense that we use in infection control. It is actually aerosolization and contact transmission of the virus, which is important. Anyway, this was the thing that people quoted extensively, and Facebook said that the press is deceiving us, the doctors are lying, this is the next major world threat, and they're just actually keeping everything away from us because they don't want to create sensationalism. And it was a flawed study. People tried to repeat this experiment, keeping all things equal, and they were never able to actually reproduce these transmission events that were described. So if you look at row now of hepatitis C Ebola, on average, 1 case of hepatitis C gives rise to 2 cases if there is obviously no intervention, for example, screening of blood and receipt of a transfusion or intravenous drug use. Ebola is sitting more or less at the same RO factor or R0 factor. HIV is greater in terms of infectivity if people don't wear condoms or take post-exposure prophylaxis, 1 in 4, so SARS. Mumps, which is spread by respiratory droplets that one generates, if you're Italian like me, you generate lots of them, the floor is covered, 1 in 10 plus. And TB, chickenpox, measles, spread by the airborne route, truly airborne, on droplet nuclei, generate in fact 18, 20, 24 cases in the absence of an intervention R0. In other words, no immunizations occurring and no PPE being worn by people who come into contact with these people, and so on. So that is important. So the reproductive number is an important thing because in a talk I'm giving later this afternoon, it's used to predict and to model certain issues. And the bottom line is that with these modelings or predictions, people come out with those bizarre rates of what is likely to happen to an outbreak that are completely artificial and wrong. So very simply, if rho is less than 1, it means that you're unlikely to have an outbreak. If rho is greater than 1, it means that you will have one. But it really implies that certain conditions are met. The rho for the outbreaks of the West African epidemic were not dissimilar from the rhos really measured in outbreaks that occurred previously, again suggesting that this is not an organism spread by the airborne route, despite the fear that people had that that might be the case. Notice that when no interventions occur, rho, depending on certain events, actually goes up and down and goes up and down. But the minute, in fact, that you start having behavioral changes, people doing the right things, reporting early for treatment, your number of infections goes down very dramatically. So behavioral changes bring down the reproductive number in an important way. In addition, we look at other factors to see how organisms actually spread and to determine whether this particular Ebola strain, the Makona strain, behaved any differently during this epidemic, given the huge numbers from all its predecessors. And in fact, the data suggested that it was precisely, in fact, the same kind of spread, again testifying that it was unlikely to be spread by the airborne route as postulated. Now, there's a lot that is known and there's a lot that is not known about this new strain of the coronavirus. So, for example, we don't know to what extent these aerosol droplets, these mechanically generated droplets, are effectively transmitting. It's not clear whether the environment is or is not important. We think it's relatively less important than contact with blood and bodily fluids. It's not clear, as you've seen with some of the cases in convalescence, to what degree minimally, mildly ill or convalescent people can spread infection. We're also not clear whether there is a strain passage effect where after multiple infectious cycles the virus attenuates. It didn't seem to be the case in this outbreak and in previous outbreaks. And also what has been very interesting in this particular outbreak is for the first time we started seeing super spreading events. Super spreading events quite simply means that one individual, instead of giving rise to two in absence of interventions, can give rise to, in fact, a huge amount of secondary cases. And precisely what the dynamics are around super spreading is not clear to us at all. So for infectious disease clinicians, and when you find the feverish patient that returns, it is a nightmare to key out what happens. Know your travel history. If somebody comes from the outside, you should all be on ProMed. You should all be realizing what is happening in all the parts of the world every single day. Because these agents have got a tendency to come into your ICUs when you least expect them. And they can appear anywhere in the world at any point and at any time. And one day you will have a hemorrhagic fever patient in your ICUs right here in Belfast. That is almost a given. When we don't know, but that it will happen is almost a given. But look at the differential diagnosis. Bacterial infection is still the commonest cause of fever and bleeding. Returning travelers with malaria, 3+, it's the top 10 differential diagnoses, malaria, 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 if there has been any travel. In my country, South Africa, in most of our HIV seroconversions, we see fever and bleeding. People get ITP, they get high temperatures, and they present with fever and bleeding. So when we get called for a query hemorrhagic event, we always test for HIV. We always test for hepatitis, because that's also an important cause of fever and bleeding, especially in fulminant events. And we, of course, check for all of the other things that are important. Remember to ask everybody that travels about non-infectious causes of fever and bleeding. In the African context, going to a traditional healer or medicine has been exceptionally important because it happens often. So I don't want to give you a list of rules, but firstly, VHFs or hemorrhagic fevers are an uncommon cause of fever and bleeding. Always have a high index of suspicion, always no travel history. Secondly, it is notorious that the primary outbreak in a community will amplify itself in a hospital because people drop their guard. They always see the bleeding patient as having hematemesis because of esophageal varices or other reasons, and they come into contact with blood, or they have in fact certain events that happen. So we have regular training programs all the time in our hospitals where we do doffing, donning, and we do a whole review of all the infections that are occurring on the African continent otherwise. So when we have imported people, we've got an idea of what diseases might be raging in those areas. We've had certain hospitals that have destroyed ventilators because they've been used on Ebola patients, destroyed equipment. All you need to do is clean them as per standard protocol. It's as simple as that. These viruses are not impossible to kill. We actually carry on with business as normal. Okay? Please remember that on splashes, although viruses outside the body can't replicate, if they're buffered in blood, they can survive for up to 4 weeks at environmental temperatures of 48 degrees in Central Africa. We found a syringe that Professor Swanepoel, who is a giant in hemorrhagic fevers, together with Dan Bausch and others, left purposely to see how long it would take for viral inactivation in blood-encrusted material in that syringe that was used to draw blood. And some 4 weeks later, there was still viable Ebola virus. So please dispose of medical paraphernalia and be sure that you get rid of anything that is important. Next important point is that we keep PPE or high-level personal protective equipment as simple and as logical as possible. Overlayering, double PPEing because you're unsafe leads to more problems than keeping things simple, right? And of course, what you want to do is protect everything. We do not, if we suspect an Ebola case, despite what the laboratory tell us, drop our infection control guard, partly because we've got a gut feeling after 25 years of hemorrhagic fevers of when not to do so. Frequently, the first PCR that comes back for a filovirus or any of the other hemorrhagic fever agents is negative. It may take 2 to 3 days for, in fact, the amount of DNA that is detected in the bloodstream to be sufficient for certain kits to pick it up. So if you're not sure and you don't have a diagnosis, we do not de-escalate infection control precautions until the patient is discharged, dead, or in fact we have a diagnosis. That is as simple as that, and that is how we normally keep safe. Finally, keep dedicated personnel there. Please be sure that there are other allied health workers beyond your particular unit that need to be warned and trained, and please also limit your laboratory tests. In ICU, you all want to do cardiac enzymes because it's interesting to see what happens to these. In various serious infections, you want to do all kinds of other fantastic tests. Out of the question. We don't even actually dedicate analyzers. They run through our normal laboratory, we evacuate it, we then clean the analyzer as per normal protocol, and we continue. We have got 3,000 patients in our overcrowded hospitals. We can't stop a health system in Africa working because there's one Ebola case or 20, right? So we do things slightly differently from you because we have to. But the maximum that we will allow, and that's all you need to care for these patients, and I know you'll be horrified as ICU people, is FBCM platelets, an automated diff. We don't even bother about the retics, and automated coagulation studies and HIV PCR. Biochemistry, at the very worst, if that's all we're going to do, is we're going to ask for 2 of the liver function enzymes, AST and LT. We'll forget about the rest if we need to. We sometimes need to do, obviously, CSF biochemistry and antibiotic levels because you're going to treat patients with antibiotics anyway. If they're in hospital long enough, they will get a nosocomial infection. And the microbiology is the only thing that we do fully because we've got to exclude all of the other agents that are part of our differential diagnosis. In the field, we don't have any of these pieces of equipment. So we look at people, we make purely clinical assessments. Right? You thumb suck everything and you pray for the best. And despite all of this, you're able to save close to 60% of people. So if we can do it with nothing, all of you can do it safely in a controlled environment with a lot more, right? But please try and limit exposures as far as possible. So I don't know why this is here because that's not meant to be either. I'm not going to tell you about pathogenesis, but it's boring. But what is important is that we actually know very little now that we've got for the first time more than 10,000 survivors of EVD, what the course is after the infection has occurred. So we've got some anecdotal data that suggests there's a wide variety of disturbances that occur, but certainly within 2 weeks to 2 months after discovery, after convalescence or into convalescence, patients really actually are still exceptionally weak and very ill. We've been able to also see that effectively a lot of the sequelae have persisted for at least 2 years after infection. These are the post-infectious sequelae. So we need to follow this cohort of survivors going forward to get the first data from this particular outbreak going forward of really how people feel in 10 years' time and whether mortality is compromised or not in some way, which has been suggested in one of these convalescent studies. Right, in terms of the other bit of information that I want to tell you, did we start at 12:30? At 1 o'clock. Okay, so we've got a little bit of time, but we don't want too much time, right? Because you all have got to go back to the wards. Was persistence in convalescence as well, and where the convalescent people may actually continue to harbor the virus, and they do. In immunoprivileged sites, people can do so. And the classical case is that of Pauline Kafferke, right? This vegan nurse that I think has made the news, well known to probably all of you, an amazing woman that really actually went to work in Sierra Leone as part of a relief effort, contracted the disease, came back and was fortunately actually one of the people that survived. However, she became sick much later, almost a year later in October 2015, and they found that she had in fact Ebola virus in her spinal fluid, and that was cultured from the fluid. Now, people like this, people with again persistence in the anterior chamber of the eye or in the aqueous humor or in the CNS are not going to be infectious. What is of concern to us are people that are harboring it in reproductive organs, especially the prostate gland in men, because sexual transmission of this virus has been documented, particularly because of persistence in semen, breast milk, and other things. So there are lots of studies, but remember, unfortunately, these studies are now measuring Ebola virus RNA. And RNA means actually very little, because RNA can come from dead organisms and from alive organisms. So to see RNA being present in a secretion does not mean that that RNA of Ebola virus is infectious at all. But one disturbing finding is that a Liberian woman who was effectively quite well had sex with a survivor some 6 months after that person was better, contracted the disease and died. So we are beginning to get variable figures. Initially we said after 3 months there's very little risk of you getting Ebola from sexual intercourse. Now we're beginning to re-question this. And again, what we need to find out is, what does Ebola virus RNA mean in terms of infectivity? Because some studies are suggesting that it can be present for up to 155 days. What are you going to tell people? To abstain for 3/4 of a year? Is this the main mechanism of transmission? We don't know. We actually don't understand that, and we don't know. So already, because of suspicion of late cases of disease, WHO always says that an outbreak is over after double its expected incubation period, which historically has always been 21 days. There are always outliers in every outbreak. But 21 days, if you have no further cases of Ebola virus disease, is in fact a good sign. If you double that to 42 days and you're Ebola-free, you can say that the outbreak in that particular region is over, right? As simple as that. Unfortunately, because of, in fact, these cases coming up that might be due to maybe fourth waves of transmission, due to sex or other mechanisms we don't understand, there is now a heightened period of surveillance that has been added before actually a country is considered to have the outbreak fully over. So we have the initial 42 days, above which we then actually add another 90 days of heightened surveillance, which complicates public health responses because it also, of course, is a cost of monitoring and following up these people for longer periods of time. So what really happened in West Africa? Well, a 2-year-old, as I told you, allegedly went in an area called Gwekadu. And we always talk about the virus and about the thousands of patients that it's killed. But we forget that probably the biggest damage of the EVD area in this West African sub-region is not so much the deaths. Those are very important. They're all human beings, human deaths. But the crippling of an already desperately weakened sector. 2 of those 3 countries, that's Sierra Leone and Liberia, through protracted civil wars, started rebuilding infrastructure and have got absolutely nothing left. Most of their healthcare worker force destroyed. There's been a significant impact because of Ebola on other programs, spraying to try and decrease malaria transmission. All of those went by this wayside. So many more deaths due to other diseases as well. Substantial economic losses talks for itself, as well as, of course, a huge amount of social disruption. It's no wonder, and it always surprises me why it seems remarkable to MSF when it said this is dreadful, it's a multi-country outbreak, the first time it's ever happened. Well, it's obvious it's the first time it's ever happened, and it's not obvious, it's very obvious it's multi-country. It happened on the border in Guinea of a little tropical village called Gwekadu that borders, right, places like Sierra Leone, Liberia. So it's clear that when you have got a border outbreak where the cases start in this area and the porous borders, it's not going to sit in one place, but with human mobility and movement, it moves to many places. So why that was a surprising event and almost superhuman, one doesn't know. Because you see the borders that we are talking about, this is when I was in Liberia. I was standing here when I took the picture, somewhere here, and here is Guinea. There is the border post. People come in and out, they intermarry, there's trade, there's all kinds of stuff that goes on. Effectively, these borders are really nothing but porous imaginary lines there are thriving communities that are really neither Sierra Leoneans or Liberians or Guineans. They're a pool of a heterogeneous population living quite happily together, exchanging trade, exchanging all kinds of things, exchanging wives, exchanging cattle, exchanging everything that you can do. So a perfectly harmonious community. Are you surprised when your position of an outbreak is there and it starts there, that it's multi-country? Of course not. It's not a magical event of a super spreading strange virus made by the Americans. It is obvious that this is going to happen because the geography lends itself precisely to that kind of event. So the current situation report is that we hopefully are now over the Ebola outbreak. Anybody that says that West Africa is Ebola free, and the WHO has made that statement 3 times, needs to go into some kind of psychiatric institution. There is nothing free about it. This virus is entrenched in these rainforests. It's probably been there for millions of years and only actually emerged when there was sufficient encroachment on a particular occasion. The human outbreak is over, and that's all that it is. But in that area, Ebola Zaire will continue, this Macona strain, and any other phylogenetic variant that develops to occur. Dashboard 10,000 survivors, it's close to 13,000, so over 10,000 for that, and that's where we're at. All the healthcare workers, in case you're concerned, that really actually got infected, and you think, well, I'm risking my life looking after these patients, and I've done this for 25 years, I need to warn you, are definitely important deaths. It's a huge amount of the health force in the entire West African sub-region, and a huge mortality linked with 881 healthcare workers that are dead. But those healthcare workers on analysis effectively turned out to be people that were very diverse in terms of what they were doing. These are, sorry, let me just move away from the slide. These healthcare workers were not simply clinicians. They are groups of people called doctors that are clinical assistants with very little training, lab staff, drivers, cleaners, burial teams, janitors, community-based workers are all lumped in the health worker category. Some of these doctors also happily worked in an Ebola treatment center and then went on to their private practice at home to look after other patients. And a lot of them simply did not wear PPE properly. So then we get the story, but one of MSF came down with Ebola. Well, MSF actually reviewed its donning and doffing protocols because even MSF makes mistakes. So if you do things properly, it is not that easy to get the disease. So please don't say, I'm going there to die if I go in this kind of outbreak, when you realize that most people had obvious breaches of infection control practices when they did this. It's also not clear at what point the infection occurred from this analysis, but it all occurred at the height of when international teams were largely absent from reinforcing infection prevention control, which really started good established international responses when people stopped getting stoned for being in the area because of various perceptions that we'll go through, really started round about the end of 2014, 2015, when again then healthcare work infections started decreasing quite dramatically. And you can see that healthcare workers more or less that were lost were right throughout the West African sub-region, being that it's a great loss from that point of view. Effectively, problems were with deficiencies in administrative controls, very poor isolation facilities, PPE not being done correctly, and also a wide variety of bad practices that are observed. So training in PPE, crucially important component of all of this. And I think what is important is that when you're in the field, you have got 4,000 organizations all trying to outdo one another. So MSF puts down its PPE and its whole bit of paraphernalia that is really different in looks and materials and components than the WHO PPE. CDC comes along and plonks more PPE onto the ground. UNICEF comes along and gives you even more PPE. Eventually nobody knows what the hell what to do, because you've got 400,000 people telling you what to do, giving you different messages, and you've got all these bits of PPE where you don't get one single consolidated advice of how to wear one simple set of clothes safely, put it on safely, and remove it without outside touching in safely and simply. These are fundamental errors, and I can't understand how many more outbreaks really to occur to tell people that too many cooks spoil the broth, right? And that is, I'm sure the infectional nurses are nodding. You must understand what I'm saying, because you can see it every day when people just don't know what to do with PPE. It's really frustrating. Okay. I don't want to go into the story of vaccines. You know that there's some amazing vaccines. Recombinant, vesicular stomatitis virus vaccines are very promising. They're still not commercially available. There are still various phases of trials. A lot of these have also been dropped. This is a good article, by the way. Seeing you'll have the talk, you should access it. That gives you really the lowdown from 2013 to 2016 of Ebola. Of all of these drugs, the only one that actually we found vaguely useful was the Vesicular, whatever it is. That's the only one we had in South Africa. ZMapp is amazing in chimpanzee models. Have you ever tried sourcing ZMapp? You haven't had cases here, I guess. Impossible. Have you tried to get convalescent plasma, which is very controversial? It's always been used in combination with other stuff, so whether it works or not, we still don't fully know. Yes? You can't get a drop of it. You can't get a drop of it. So if you do have a case, to try and source this stuff is almost like asking the Messiah to rain gold upon your heads. It's impossible, right? So for heaven's sake, for the moment, stick to common sense, good supportive care, and do whatever you can. And if you can get hold of the things, good and fine. But all I can say is that when the chips are down and you look for it, there's not one person who's willing to give you a source, including the Royal Free Hospital when we needed some urgently, and we got zero. Little dig, yes. It's not you. If it had been you, it would have been a completed. I'm sure we would have got doses because I've got friends all over Belfast, and you would have helped us out. But really hard to get. Now, do I blame the Royal Free? No, not at all. Short supplies, when you're sitting on gold, you don't give it to anybody else. That's the bottom line. And that's the reality of health. So the obstacles of the outbreak response are effectively human. And this is the only time I'm going to make here a clip, just for you to get some kind of impression of really how appalling it is to try and be in these areas, how the human element really gets to you. You see, people go into homes, remove bodies, don't explain what is being done to anybody, and of course create a huge amount of devastation. And for us, the biggest obstacles to an outbreak response is not really so much the virus. That's the theme I was going to get to when I spoke about superbugs before. But in fact, everything else that goes with it, fear, denial, media, and fake messages brought about social and conventional media, rumors and panic, are the things that really made the few thousand cases of Ebola become 28,000, right? People in the region are poor, education is exceptionally low. Infection control practices, non-existence. Healthcare delivery and infrastructure, virtually non-existence. Lots of fear and anger and suspicion was driven towards international teams because they thought that we were harvesting organs, one accusation. I'll show you the other accusations from Facebook as well, that we were there to kill people. So as usual, the international teams and the doctors got attacked. Now, just imagine when you don't have education, your person that is taken out of your home is alive when you last see them. They come into hospital and they go out dead. Yes? It doesn't matter how hard you've tried. The perception is that they've gone in to die, and you were an agent of the death in one way or another. People are always insensitive over cultural and religious issues. You're dealing in West Africa with Christians, Islamics, all kinds of religions. And if you don't follow and understand, not as a doctor, you need a social anthropologist with you, the cultural paradigm in which those communities work, and if you don't respect those traditional value systems, you will actually fail in your epidemic response. Outbreaks that have been right throughout have always shown that. Denialism, there's no such thing as Ebola, very strong sensation. Misconception about the causal etiology, that in fact traditional healers were inflicting it on people because they were bad. So if you were a poor survivor And or you were seen entering a treatment center because you wanted to be evaluated to see whether you were an early victim or not, and you exited it alive, you were most likely to be stoned or completely be discriminated and not allowed to re-enter your village because you were seen entering a facility where all these bad things happened, right? So making it very difficult for, in fact, survivors to do anything. And also all kinds of other misconceptions that came about, that were some of them politically driven. The poor survivors for the prize of really surviving one of the worst diseases ever seen, regrettably, were the people that I felt most sorry for, because often those people had to leave their communities, their families, their friends, and move, in fact, to another village. So we tried, as we did in the previous outbreak, to give a certificate of clearance of infection, saying this person is no longer infectious, and getting community leaders and workers together with us to show that we were quite happy to be close to the survivor, to be touched, to be hugged in front of everybody, so they could see that if the people that are creating the disease are happy to touch them, then in fact they must be safe. The integration of individuals like this was so rare, it was absolutely too distressing for words. So there's another victim dimension beyond the dead and beyond the crippling economy and others, and these those that had actually the luck to survive, but the misfortune not to be able to be reintegrated into their own community. There were strange messages coming out from WHO and health authorities. One of them is do not eat bush game. How stupid can you be if your initial contact comes from the bush and a West African vegetation survives? They've got no herds of animals. They survive on a bush economy and bush game, and it's the only source of protein. What are you doing telling them to stop eating meat? It's just a bizarre message. Social distancing. Don't touch anybody. You're not going to go by closing a disco. You're not going to impact an Ebola outbreak anyway. You will not be jiving even in your early stages of Ebola disease. That we can actually guarantee to you. Closing markets, a disaster. You're ruining the economy of already an impoverished area, and you're destroying any possibility of livelihood for people like that. Vaccination was very sensitive, an important strategy, and I think a very interesting strategy, but full of ethical issues, which I won't even start going into now, and again, exceptionally dangerous. You call people in, you say, this will hopefully protect you. If it did, we will give you a vaccine, and despite the vaccine, they die of something else. You were the person that gave the vaccine, you were the healthcare worker, and you were the person that killed them. So the complexity around vaccination was also, in fact, exceptionally difficult. But it is something that is very important, and we'll see what happens with it going forward. Draconian quarantine measures, Kathy Hickox came back, and if you recall the Kathy Hickox case, she was virtually not allowed to get back. Stopping of flights, border closures, huge economic disasters, as well as operations or the closure of iron ore mining that destroyed the economy in many ways. If you look at Facebook, America was blamed, zombies were blamed, witchcraft was blamed, Jesus was blamed, the Jews were blamed, ISIS was blamed, everybody was blamed, except in fact the virus itself. The Catholic Archbishop also, by the way, you've got to see this one because it's interesting, thought that seeing we've blamed everything else, we might as well also start blaming Catholics. This is an educated person, all gay people, not that they're very many in Monrovia, but in fact, why not? It's a punishment from God because you're gay. Let's add gayness into the world, and we've blamed absolutely every possible person we could put in judgment on. These are learned people that come out with these messages. And of course, beautiful from the social media is that bleach is so amazing, which we agree with, it's excellent in these things. Inject it, 20 mils they give you specifically, to your bloodstream, or take it orally and clear all the bone in your system. Awesome stuff, isn't it so? So you can understand that with all these misperceptions of the rubbish that comes out, people get angry, they get suspicious, they get mistrustful, and of course, in fact, the stoning of healthcare teams and others really does occur. So, to conclude, the microbe is Ebola virus. We can contain it. It can't do much on its own. It's a piece of, for God's sake, RNA that is packaged in some way. It won't survive in any way unless you get to it. You have to make an effort to get to that virus. And man is not its right host. We can create mechanisms with IPC to stop the microbe entering us with sensible behavior. But what you can't control is an environment that is full of bizarre human behaviors, flooded with incorrect messages, with misperceptions, with aggression and other issues. So superbugs, really, I want to argue, don't exist. They are all caused by this intrinsic human behavior, even the ones you create in your hospitals because of antibiotic abuse. You are abusing or misusing or overusing antibiotics. You're creating your own superbugs. They're all driven by man. So if that is true then, which is a superbug, as we asked earlier? Is it in fact the virus, Ebola, or the multi-drug resistant organism, or is it the human? Just something for you to think about. Thank you.
Adriano, on behalf of the Belfast Trust and SAFEtember, thank you very much. My knowledge of Ebola has increased exponentially. There's probably time for about one question. Does someone have a question they'd like to ask?
How long does the virus survive after bodies are buried?
After?
After the bodies are buried?
Okay, so please remember that shortly after, the minute you bury a body in heat, decomposition is quite rapid. So, in fact, shortly before death, you already get gastrointestinal bacteria that go into the venous system and start your own personal decomposition. The lytic enzymes of bacteria that decompose you are so powerful that a virus has got no chance to really survive too long. In a fridge, it's a different issue. So if you slow decomposition, beware. Topsy laboratories and other things are an issue. But once it's in the ground, ironically, decomposition occurs. With decomposition, viral survival is not likely to occur for very long.
Peter, quick one. Is there any global push to standardise responses to?
Oh, you are the most amazing man. I've been to Dan Bausch, who's at WHO at the moment, and we're writing a paper to try and make a paper plea to standardize so that everybody does the same thing. I don't know if it'll go down well. There are too many interest groups. But that's exactly what we think we need to do next, and that we should have done years ago, because, this has been the same pattern of obstruction, outbreak after outbreak. But it's an excellent point, and it's what we are going to put out as a publication, which I think is going to have zero impact whatsoever.
You said keep PPE simple.
Yeah.
And obviously the instruction, one set of instructions. Did you double glove?
Oh yes, we did. We did. So PPE is not just ordinary standard precaution. We're talking, in fact, I don't know what you call it, Irene, here. We call it high level or enhanced PPE for VHFs. What do you call it? We call it high level or enhanced. These are full body suits, impervious gowns, so covering everything from top to toe and double gloving, yeah. But a lot of people overlayer it. They will cut, for example, they'll put a ductile mask sticking out over a surgical mask. They do all kinds of bizarre things. That's the kind of thing that I think you should not be doing. So, in fact, Irene and I gave a talk, co-gave a talk on dressing up and dressing down. We're entirely on the same page. So if you want to ever get demonstrations on how to do it, nicely, simply and sensibly, Irene Thompson's the person to do it for you. Yeah.
Has she been videoed doing it? Is it not?
And unfortunately not, but she should.
Have been? Good.
Yeah.
Okay, well, look, I think everybody probably has to get back to work, but if someone wants to stay behind and ask some more questions, I think Adriano will. But you have to go to the PHA for.
We've got another talk, but it depends in time.
Yeah, so maybe for 10 or 15 minutes you'd be here. Okay.
Okay, 100%. Okay. Thank you very much. Thank you.